I am genuinely delighted and honoured to be able to introduce and invite the next speaker up. Joel, who's been a close friend and colleague, must be close to a decade now. I've sat on multiple MDTs with him. We've shared patients from far and wide. But Joel holds a very privileged position as an allied healthcare professional in the spinal sphere. He is somebody who has first-hand experience of what spinal surgery is, not because he performs it, but because he has had spinal surgery. And not just that, he's been able to rehabilitate himself and countless, if not thousands of patients as a kineticist across the world. He's one of very few internationally renowned therapists that is able to rehabilitate spinal patients. He's also an innovator. He has held the Spine Exchange, which was a forum for patients and clinicians alike to share their experiences. And more recently, he has launched an application called Vertera that is likely to change the way patients and clinicians interact with one another, both pre and post-surgery. Won't take up any more of your time. Joel Proskowitz.
Ahmed, that goes way beyond what I had expected, so thank you very much. Unlike my colleagues, Mr. Malik and Mr. Grahovic, I'm going to be a little bit more dismissive of the hydrostatic diurnal changes of the intervertebral disc. And the reason I say that is because regardless of what time of day it is for me, I am always short. Right. So I've got a lot of disclosures. I disclose that I've had vertebrogenic pain, facetogenic pain, discogenic pain. I've had radicular pain. I've even had a radicular traction injury to my L5 nerve, which the pain is indescribable. However, I was blessed with all of these, and it takes me back to my backstory. In the late 1990s, early 2000s, I was diagnosed with an unstable L5-S1 spondylolisthesis. Over the next 20 years, I managed to look after myself conservatively, and I was involved in exercise and movement management, and everything worked well until COVID hit, and I started to get a progressive neurological deficit, and I landed up having 7 spine surgeries in 12 months. Now, you may ask yourself, why did I keep on choosing the same surgeon? Well, my case was really complex, and my surgeon has put me in a very, very good position. I now have a 360 fusion at L5-S1, and what all of this has afforded me is the ability to now be in surgery every week to observe these wonderful surgeons doing their work. I'm a huge advocate for spine surgeons. I believe the work that they do is fantastic, and they can really change people's lives. So today I'm going to be speaking about, first and foremost, prehabilitation for spine surgery. So what is prehabilitation? Essentially, prehabilitation is to optimize the patient from diagnosis to surgery to reduce complications and enhance return to function. It's a very important component, and a lot of individuals, particularly patients, are now requesting to become more involved in prehabilitation because of the traction it's getting. However, if we go back in time, we used to think that prehabilitation was very much a unimodal concept that just comprised of exercise. And in actual fact, if you go back to 2002, there was a paper that was even talking about prehabilitation, and the conclusion was that an exercise program that consists of warm-up, a cardiovascular component, resistance training, flexibility training, and focusing on functional tasks was what made up prehabilitation. Over the last 20 years, things have changed significantly. In fact, one of my colleagues at the Medical University of South Carolina, a very smart physiatrist by the name of Jim Eubanks and his group, have put a lot of time and effort into studying prehabilitation, particularly for lumbar spinal stenosis patients who are going in for surgical interventions. And they did a paper and essentially came out, this is a recent paper, and it came out that the emphasis on education, both pre- and post-operatively, and expectations about what the patient can look forward to after their surgical intervention, staying active, goal setting, frailty management, and nutrition are very important components of the prehabilitation cohort. We now understand that multimodal concept consisting of physical training, emotional, and when I say emotional, I'm talking preparing the patient and getting them to understand what surgical procedure they are having, what pathology they are dealing with, and what the timelines for recovery are. Their lifestyle, stuff like cessation of smoking, enhancing just their overall physical well-being, and their expectations now make up prehabilitation. What is really encouraging is that over the last few years, there are many papers that are now being published on the efficacy of prehabilitation, including all of those components that I've just mentioned. Roger Hart, who's a spine surgeon based in the US, said something that stuck with me for a very, very long time. I heard him say this about 5 or 6 years ago, and he said, surgery is a controlled injury. It's a controlled trauma. And sometimes we don't fully understand what it's like for a patient to go through spine surgery. I can tell you this, spine surgery is life-changing. Is it for the better? Is it for the worse? Don't know. Only time will tell. But it changes your life. It's a traumatic surgery. But if we can prepare our patients, get them to understand what's going on, we can play a role in putting them in a very strong position to have a successful long-term outcome. So to define prehabilitation, specifically around spine surgery, it's to prepare patients for their surgical procedure with the goal of enhancing their intrinsic ability to buffer against surgery-related declines in function and well-being. Secondly, it's to improve patient satisfaction by aligning expectations with actual patient capabilities and anticipated outcomes. So, to conclude my thoughts on prehabilitation, simply, it comprises of an exercise-based prehabilitation which improves physical function. There are psychological interventions which are extremely effective components. We need to address modifiable risk factors, which again can play to significantly improve outcomes for patients. Education and exercise together deliver the broadest benefits. That is one component of that patient journey. And the next component, which is something that most clinicians will have dabbled in, and that is rehabilitation. Someone has a spine surgery, now we need to rehabilitate them. And what I'm going to do is I'm going to quote a paper from Jeffrey Wang and his colleagues, which is the reoperation rates after a single level lumbar discectomy. This was done on 13,600 patients for a single level lumbar discectomy. And what they found was there was a 4-year reoperation rate of 12.2% after a single level discectomy, and roughly about a 38.4% within 4 years of those patients would go on to have a lumbar fusion. The reason I bring this up is because we need to question how we rehab our patients after spine surgery. And I'm going to use a case study here of a patient who had an L4, L5 360 fusion. You can see here on the CT scan, for those of you, if I can just outline this, this is a beautiful operation, a very well-placed L4, L5 cage with backup screws and rods at the back of the spine. And this patient at the stage was a 47-year-old male, very physically active. And his past medical history includes an L4, L5 discectomy 10 years prior to his fusion. So in 2020, he had a 360 fusion primarily for the onset of intractable axial back pain. He had no radiculopathy or radicular pain symptoms. But this is what he was told, and this is very interesting. He was told that he would be back to normal functioning and activities within 5 weeks post his surgery. I still don't quite know how he got to hear that, because I doubt the surgeon said that. I think that's what the patient wanted to hear. So 6 months post-op, he presented to me with ongoing low back pain and new symptoms. After doing a very thorough medical history intake, and his history intake, I wanted to understand from him what he was doing regarding his rehabilitation. And he said to me, Joel, I started Pilates, full 1-hour Pilates classes, 3 weeks post-surgery under the guidance of my clinician. And within 7 weeks post-surgery, I was doing resistance-based workouts. I'm hoping this is going to be big enough because this was the outline of what he was doing. So this was an alternate day 1 versus day 2, and this was done between 4 to 6 times a week at 7 weeks post-surgery. And as you can see, there is a lot of stuff within that program at such a very early stage post-operation. However, along with all of this, you'll note at the very top, prior to him doing any of his resistance training, he would either do some cardiovascular work for roughly 10 to 30 minutes, do a Pilates routine, and then do his strength training. I think we can all agree that this is way too much, too soon. The primary thing after a lumbar fusion is to fuse. It's not to get fit. Fitness and strength will come in time. But if we rush that process, we are going to have problems. Another interesting case is another 360 L5S1 ALIF fusion. And this particular gentleman, 54 years old at the time of surgery, school teacher, not very well acquainted with any type of formalized exercise at all, in actual fact. But past medical history is unremarkable, non-smoker, relatively healthy. And he had his L5S1 fusion in February of that particular year. And he had it for both a radiculopathy and axial back pain. And post-surgery, he was symptom-free. Now, at 3 months post-op, under the care of his clinical team, he was told that he needed to get strong. I have absolutely no problem with anyone getting strong and lifting weights. In actual fact, that's my favorite pastime. But when you look into his history, and he has no understanding of how to lift weights, he hasn't been taught how to do it properly. He was told that he needed to purchase two 20-kilogram kettlebells and do kettlebell work. Now, for anyone who's in the rehabilitation game, you will know that the skill of lifting a kettlebell, being able to swing, being able to clean and jerk a kettlebell, is a skill that you need to acquire over time. So interestingly, if I can just run through this, if you take a look at his post-op scans, he never had CTs, and I asked him to speak to his clinician to get a CT scan, and this was 3 years post his surgery. He was not fused, right? So the hardware is in place, but there's no bridging bone between L5 and S1. Now the question is, was he loading too much too early? Did he disrupt the fusion process? It's just a question. Anyway, just some rehabilitation takeaways to leave you with and to think about. Back pain versus spine surgery is not the same. We need to treat them differently. Take it slowly. I believe too much too soon is not going to be good for any post-spine surgery patient. We're in no rush to cross the finish line. And movement quality matters. You need to learn how to move well, and you need to learn how to move a lot. With that in mind, I am beyond grateful for being allowed to be on the stage, and thank you to all my clinical and surgical colleagues for allowing me to just spread the word of good pre and post rehabilitation. Thank you very much.
Thank you, Joel. Always a pleasure to hear you speak and to give an alternative perspective that is critically important. We've heard about really quite substantial, significant spinal surgery. Our next speaker is a great exponent of minimally invasive techniques, laser discectomies, and making the incision that much smaller so patients can get up and go quickly. I would like to ask Mr. Imran Rafiq to come up and speak. Thank you.
Emma, thank you for your introduction, and thank you everyone for being here, not just being here, but staying that long as well, to be honest. Just about my talk, I would like to say it's not just minimally invasive, but also I want to label it like from NCN to Silicon Valley, that how spinal surgery for front-end landscape is changing. So the topics I'm going to cover quickly is not just MS techniques, robotics, navigations, that it all helps in our surgeries, and then regenerative therapy and AI. No talk is nowadays complete with the AI, to be honest. So everybody is aware spinal diseases has the biggest burden globally. Yeah, it has been reported as surpassed the cardiac diseases in the WHO list now. Last NHS white paper showed that the burden to UK economy is now gone up to 12 billion. So why this all MI surgery? How can MI surgery can help this? So there is no doubt it is the foundation of the modern spinal surgery now. How? So we used to do a surgery with a big incision in last 20 decades, and you can see how the things has evolved over the years. It's not just the incision. So incision with the open surgery for a single level decompression fusion used to be 8 to 15 centimeter. Then came the tubular surgery. Example is just down here, where you use a special retractor to dilate the muscle. And then came the endoscopic surgery. From 15 centimeter, we go on to less than a millimeter now. It's not just the incision, it's the blood loss. It's the muscle dissection. Probably this morning you might have heard the topic about the multifidus, rotatus, muscle biomechanics. So all dissections will cause more disruption of multifidus muscle, causing significant disruption, destabilizing muscles around the spine, and then this can challenge your outcome. So certainly with this, we have gone to moderate in tubular and almost minimal with the endoscopic surgery. Hospital stays have reduced from standard surgery, which used to keep the patients in hospital for 3 to 5 days. It is now only 1 to 2 days with the tubular, and same day discharge with the endoscopic surgeries. And then return to work. Certainly the patient outcomes, where it used to be like 6 to 12 weeks to get to the routine work. Now it is 3 to 6 weeks with the tubular, and probably 1 to 3 weeks with the endoscopic. How have we achieved that? It's not just the surgical technique. It's a lot of advancement. In the tubular instrumentation like tubular retractors, surgical techniques, and the evolution of the endoscopic spine surgery. So just to give an idea, traditional surgery used to happen just for a single level. Sometimes in a high BM patient used to be almost like half of your spine being exposed, which is now being done with the stab incisions, or some using with the special jigs to much smaller dissection and much smaller approach. This example of the tubular retractor, we can see a special dilated tube is passed into the patient without any big incisions to dilate the muscle and do the same job which you used to do with the open surgery. And this just to give an idea how endoscopic MIS and traditional surgery incisions varies. So there's no doubt that yes, with the use of tubular retractors, endoscopic surgeries, the patient outcome surgeries, everything has been improving, and there's enough abundance of literature to support that. Then technique also improved with the use of the percutaneous screw fixations, where we can put the screws at the level of the skin without opening the skin, and then same techniques of implantations. Surgical navigation. Certainly, this is one of the biggest paradigm shift, which means patient-guided surgery with near perfect accuracy. What does this mean? Consider it just like using a real-time 3D navigation system that like use in your cars or in your phones, but being used on the spine. So we use special radiological tools, like this one is an O-arm in theaters, which communicates with the reference frame on the patient, and then a navigation worktop station. So essentially what we are seeing, the patients, even before we open the patient or do the open surgery, we can see the spine inside. So we don't need to make any big incisions. With the systems talking to each other, we can see how our implants will be positioned. We can change the trajectories. We can select our implants. And certainly, this can reduce the patient mobility. So navigation technologies is booming at the moment, and that's the way forward also in the coming years. There's a lot of companies who are offering that now, and slowly, it will become mandatory probably next few years, where navigational technology has to be used in any complex spinal surgery. It has shown excellent accuracy in the screw placement compared to the freehand techniques, such as we used to do while we used to open the patient, look at the bony landmarks, then do implantation, or you used to use the x-rays. Role is much bigger in complex and the revision surgeries, where it makes it much safer. It has also reduced radiation exposure to the patients and to the surgeon himself. And recent data has shown that the chances of malpositioning of an implant is minimal, is getting less and less with the new navigation systems. And with the augmented reality, which is the next way forward, it has been proven that the use of the navigation and AR changes not all the surgical outcomes, theater efficiencies, patient outcomes, but overall the whole journey experience is going to be enormously changed. This has been FDA approved currently, but we are expecting that soon we will be also having it in our practice. Robotics. So robots are like a myth. People think that robots will be walking in theaters doing the surgery. It's not the case. Surgeon is still the leader, to be honest, yeah? Yes, but it is prescient beyond human capability. So it's just sorry to shatter the dreams. I suppose that some people, some of the patients have asked that, oh, is it something like you see in the Star Wars or androids coming and operating us? Is it not in our generation? Probably yes, but we're not there yet. So how does robotics work? So robotics is just simply a robotic arm, but it communicates with the navigation, and it's exactly the same thing like I said before, 3D navigation system looking into your spine, but now we have got the steering, actually lane-assisted steering in your hand, and surgeon is the driver. So essentially, the robotic arm does not let you do any misperfect placement of the implant or any deviation from the planned trajectories or pre-op planning. Just to make you understand how it works. So robotic arm is here, and then you have the navigational system talking to the reference frame on the patient, and that generates the images which guides the surgeon how to put the implant and decide about the safety of the implant positions. Numerous providers are there, and all of them has got the pros and cons, but all of them has shown high level of efficacy, safety, and improved patient outcomes. Regenerative therapy and stem cells, probably quite a lot of people you will know about that. It is basically from symptom management to biological repair. And certainly it will be one of the horizon or one of the evolving field of the spinal surgery or related pathology. How does it work? I'm sure everybody's aware of how the discs degenerate. And basically, it's very simple. The aim is to reverse the process or stop the process. So as we all know that with the process of degeneration, disc architecture changes with the change of connective tissues, hydration, and everything. And the aim is to use the biologics or stem cells or gene therapy to stop that process or reverse that process. Are we there yet? Probably not. There are two big ways of looking into this sort of a treatment process. Use of stem cells or PRP in the biologics. Currently, none of them has been FDA or NICE approved. But yes, a lot of research is happening, and both of them has supported the research in these areas. But yes, off-label use is there. Stem cell therapy probably slightly ahead because phase 2 and phase 3 clinical trials has been very hopeful, which has shown some disc regenerations and hydration of the disc. But they are still not as, they are not being used in a human, and still a lot of studies needs to happen. So I don't think so. We are looking their common use in our practice for at least a decade probably, but we'll see. But yes, PRP slightly more off-the-label use. However, it has not been again approved by the NICE and FDA currently. AI. Probably this is a game changer in the coming years, which will not just going to impact the surgeon, but probably everybody sitting in this room. It is transforming the diagnosis, planning, and even the outcomes. Huge is happening using the deep learning platforms and AI platforms, from improving our diagnosis, where deep learning platforms working on a lot of data which is there will be helping in not only diagnosing the patient, but also predicting what surgery can be considered with the best outcome. Very interesting concept which is developing and is already FDA cleared is neural network models. These are the AI platform models. So think it like a advanced computer system having a lot of data which can take the patient history and then imaging in consideration, and based on all the literature available there, MRI, CT scans, literature, it can predict what surgery can be the best in the patient. However, current recommendation is that this can be part of the MDT, but it has to be clinician driven. Similar concept, FEA AI driven, which is again an advanced platform which is FDA approved again, where it can predict whatever intervention is done to the patient in terms of instrumentation, fusion, cages, the after effect of the human spine. So we can predict our risk of future adjacent segment problems or patient failures or segmentation or kyphotic problem, surgical kyphosis problem. And then certainly the AIs are changing the way we are doing our patient managements in outpatient, MDT discussions, and this is going to stay and this will going to impact. However, the key thing which I want to say that despite all these advancement, the MDT approach still remains the key. And there's the surgeons, physiotherapists, nursing staff, pain intervention, and the radiologist. And yes, somewhere there we have to incorporate this in our practice, but it is not going to replace what it is there. So what I can say at home, take-home message that yes, all these advances, innovations are coming. They will going to change our practice in coming decade. We should be prepared to embrace them and take them as a helping tool rather than giving, we cannot say that that is going to replace our surgical skill or human acumen to decide about the patient decision surgeries. Thank you.
Thank you, Imran, for showing us what the future looks like, and it's certainly bright and exciting, and we're all very much delighted to be occupying that space. Lots of you had many questions about the next topic, so won't take up any more of your time. Mr. Malik, come and tell us about BVN, please.
Yeah, I think there was a question now we're going to talk about basivertebral nerve ablation. So why we think the basivertebral nerve ablation, we can do that because it's, we established with time, it's clearly a pain generator, it's minimal invasive, and it lasts long. It's not like radio frequency, which we do for facet or for any other reason. So when I have these clear pathologies, I know how to treat that. So if I have, this is a very clear pathology here, which is a disc prolapse, which presented with back pain, leg pain, I know how to treat it surgically. I will remove this, and that will relieve the patient pain. This is the spinal canal stenosis. That's another cause which normally gives us the back pain and difficulty in walking, and I know that how to treat it, and I will get rid of the pain. Then there is a spondylolisthesis, another cause of, well-known cause of the pain. And what we do, if the patient is not getting better with a conservative treatment, we offer a surgery, we reduce the deformity, we fix and fuse. The problem arises here. When the patient comes to me, he has got no neurological symptom, no leg pain, just a back pain. I have done the scan. On the scan, it is not showing me any surgical treatable pathology. It's just a black disc. What I will do with this patient? I will send the patient for rehabilitation to you guys and subsequently for pain management. And if patient get better, fine. If the patient is still in an intractable pain, you guys get tired as well. You start writing a letter back to us. Mr. Malik, I tried my best, but patient is not getting better. And patient will say, oh, he has got all sort of injection. He initially went for caudal epidural, sometime he went for a nerve block, then he has got a facet injection, then facet rhizotomy, and not getting better. And really, there's no clear answer here what to do. In the past, when we think that patient has tried everything and patient is sick and we are sick, he's coming again and again, we offer them to fuse the level. And we give them the success rate of 60%, because if we have a genuine cause like a listhesis, we know we can produce 80% patient do get better. But if it is a just pure black disc, we don't know whether it will get better or not. We say it's a 60% chance, we'll take the disease disc out, you might be better. But it has got downside as well. The pain might get better with that, but the downside is that after some time it will start affecting the adjacent level because you stop that movement at that level. And patient end up having an adjacent level problem and come back to you with a similar position. So I think with our scientific knowledge and with the laboratory studies, we find that there is a nerve. We always think about the nerve which is going in the spinal canal and then spinal cord. We think those are the nerve, but there are peripheral nerve as well. And one of these nerve is called the basivertebral nerve. That basivertebral nerve comes out of the foramina. If I divide the vertebral body into 3 parts, so it's almost 40% of the vertebral body and the 60% anteriorly. At that level, there is a foramina which is called the basivertebral foramina, through which the nerve arises, which we call the basivertebral nerve. Then it divides into 2 branches, which we call the sinovertebral nerve. And these sinovertebral nerves then give the nerve supply to the end plates. And after end plate is our disc. So, and they carry the sensory fiber from here to the spinal cord to the brain. And our knowledge has shown that throughout the life, what we think, these are the pictures of the basivertebral nerve, and they're showing how it on MRI look. We clearly, everybody has a basivertebral nerve on the scan if we do. And that's a normal thing. And if we see another picture of basivertebral nerve, if we have, this is the sagittal, but if we see the axial cuts, we see there's actually two basivertebral nerve. One is going this way, and one is arising here, and then dividing into branches this way and that way, right and left. And we were discussing this morning when I was giving a talk that when the disc is normal like this, healthy, it acts as a cushion. And people are normally healthy and not in pain. As soon as the nucleus pulposus start degenerating, it cannot support the end plate. And when it cannot support the end plate, what will happen? It will lead to cracks in the end plate. And when there are cracks in the end plate, it opens a floodgate for inflammatory substances from the disc to move into the vertebral bodies and crosstalk with the marrow of the vertebral body. And when that crosstalk happens, it produces a lot of neurotization and inflammation in that area, which we call modic changes. So there are type 1 and type 2 modic changes. These are actually, a modic was a radiologist who first time described that. And these modic changes are the one actually which are the source of pain. And on the basis of that, because that is well established that modic changes are the source of pain, and we were offering the fusion, but we thought that this, because the basivertebral nerve is supplying, if we kill that nerve, that ideally should cure that pain, because this nerve is the source of pain. And even if we get rid of that nerve, it is not going to cause any harm to person, because it's within the vertebral body. And how we can establish, obviously on the MRI scan, as I was saying, is showing clearly type 1 and type 2 modic changes. And also, if we do a SPECT CT, I think when they started doing this procedure, it started in US 20-center, multi-center trial, I will show that. But they are treating on the basis of MRI scan. And I think we added this on the SPECT CT as well, because we think that SPECT CT, I know, patient might come to us with have a modic change, but at the same time might have a facet joint disease, might have a SI joint disease, might have an issue with the pars. So how we differentiate that? Or might have weak muscles. So we don't know. Exactly in order to establish that really is causing the pain, SPECT CT is instrumental. It will pick up the pain generator at every single level and will let you know exactly which is the source of pain. So this was the first trial, which was done by Fishgard in 2018. And what they did actually, this established the criteria. And we are exactly following the same criteria. If somebody is having a low back pain, no radicular symptoms, on the end patient, the pain is quite troublesome, has tried a 6 month of conservative treatment in the form of physical therapy, pain management, and is not getting better. And there are certain tests which we do that patient pain comes on flexion when moving from sitting to standing position. All those sort of things suggest there's a mechanical back pain. And that back pain, because it's arising from the end plate, before we used to call this pain, which is we thought is coming from the disc, discogenic back pain. Now we change the name and we call it a vertebrogenic back pain, because it's actually arising from end of the vertebral body, not from the disc itself. And SPECT CT also helps with that as well to see whether the disc is involved or not. And then obviously on the MRI scan, there's the type 1 or type 2 modic changes, and there's some end plate cracks which cause the end plate damage. That's what they start using to treating the patient. And what we did, we added on that the SPECT CT. We definitely want to have a SPECT CT. And also the MDT discussion. So these 2 points we added that to make it more precise that everybody should not be doing that, and where it is happening, it have a proper MDT discussion, and the SPECT CT is generally very helpful. So these are the SMART trial, which is the name of the trial done in 20 different centers in the US. And this is the probe which is being used, and that's the probe controller which generates the heat. And that is the probe itself. This is the needle, how we start that. And then they produce their result. So if you see, this is the post-intercept result. So before the patient you see where the ODI was. It was hovering around 50. And with this treatment, within 3 months, it dropped down to almost 20, significantly improvement. Similarly, if we see the visual analog score, which was 7, dropped to almost 2.5. And there was crossover as well, because the patient was pooled in 2 different groups. And because the patient was in a different, the group which was treated conservatively, not given this treatment, they were in so much pain. After 6 months, they were allowed to enter into that trial. And when these patients were treated, they come to the same level as well. So this means it is an effective treatment. And same, the time is again an issue. So this is another results of SMART trial. I will move on now. So so it sees that with this SMART and INTERCEPT, both trials shows a 4%, 4+ improvement, or 40% almost, with a visual analog score. So how we do this? It's a very minimal invasive. You put no incision is being given. It's just through a Jamshidi needle, through a stab incision. You put the needle into one side of the pedicle and move to the other side. And then once the needle is in a good position, you remove the needle, you put a probe, and then you generate a heat. And that will gradually kill this vertebral, this basivertebral nerve. So it's you don't need to put any implants, and there's no cut, no incision. So patients are usually discharged on the same day. And they ask me when they can resume the activity. I usually allow them to do after 24 hours. So that is actually the procedure in the surgery. So you see that we put the needle here, and then we thread the probe up till here. So this means it is taking the both side nerves. So this is taken, and then we do the procedure on the lower level. Same thing, we come on the opposite side. So we give a one stab on this side and other on this side, and then we take care of all the basivertebral nerve here. And if you do, and here we give a heat almost for 15 minutes at 80 degrees. And if you do a post-operative scan after 3 months, you will see these sort of lesion like that. So these are the lesions which produced by this probe. So, and this is recently a pool study done where they put all the 3 studies together. And this study clearly showed that in aggregate analysis of the patient with vertebrogenic back pain, utilization of conservative care, opioids, injection, radiofrequency, they significantly went down. Almost 60% patients become free of that. And similarly, the rate of the fusion went significantly down as well. So this treatment worked. Only advantage with this treatment as fusion is because if we have done the fusion, if that doesn't work, we can't do anything. But if we do this, it's just a simple procedure, slightly bigger than injection. And if that doesn't work, you still have an option to go for a fusion. And in this trial, it's claimed that 70% people do well. And as I was showing in my studies, that they are even maintaining up till 5 years. If you see here, up till 5 years, so this means it has a longevity as well. So I will conclude now that it reduces the pain both on ODI as well as visual analogs. It is a long-term treatment. It improves the functional outcome. It reduces the opiates need, improve quality of life. And there is no violation of normal spine. Your anatomy remains the same as it is. And it's very safe as well. I think so far, thanks God, I'm doing this for last 2 years. We haven't got any problem or complication or any risk. In the trial, which in done US, there's only one noted complication of nerve injury in almost whole trial, which was done in 200 plus patients. So this means it's a safe and it can be tried. So I think we have a lot of talks which we give today. So now I thought we should change a little bit experience and we should have a direct patient experience. So because this is about the endoscopic discectomy, as I'm doing for a long time now, I've done more than 1,500 cases. So I was not sure which to choose. I thought just was which I have done last week. So I just invite them. So this is the patient which I did
Hi, my name is Jennifer and I
2 weeks
recently
ago.
had an L5-S1 right-sided endoscopic discectomy, and just 2 weeks post-op I'm feeling great. Honestly, it's been life-changing for me. I experienced almost immediate pain relief after the surgery, which I never thought would be possible. At its worst, the pain became so severe that I had to lie down in bed. I couldn't get up. I was physically bent over and my back would seize up with intense sciatica pain radiating down my right leg. I was waking up at night in severe pain. I couldn't sleep. The symptoms became so limiting that I couldn't tolerate car journeys longer than 30 to 40 minutes. I had to stop going on even walks in the evening. It affected my activities of daily living and it also affected my quality of life. I had been dealing with this pain for nearly 2 years and went through 3 injections, physiotherapy, and a course of Pilates during that time. The first injection worked for a while, but my symptoms gradually returned. I was 22 years old at the time and just starting out in my career, so I really just tried to manage things conservatively and held out hope that further injections would help. I was hoping for a miracle, but it turns out the surgery was the real miracle for me. I was constantly taking pain.
What I did here? I think stopped somehow. Okay, I will move to next one then, sorry. Now we have a patient here among the audience, so I will ask Farid to come on, please, and share your experience. This patient was, by the way, in Ireland, so she cannot manage to come. So she came right from Southern Ireland, Dublin. She's medics herself, so she flew from there, she went back. So, but then we have a Farid here. So, Farid, can you please introduce yourself and just what your symptoms were and how you were feeling before and now?
Okay. First of all, thank you very much for
When you
inviting
had
me
a
today.
surgery, Farid?
Sorry?
When you had a surgery? When we did
I had it last Saturday.
Last Saturday.
6 days ago.
6 days ago.
Yeah. So that's why I'm free and available to come along today. So my story is very similar to the girl who was talking on there. So I had back pain. I think it probably first started about 3 years ago. Sort of manifested through pain in my butt and down the outside of my leg, my lower leg. I had nerve root injections. That worked for about 6 months. Then it started building up again. I had injections again. My back was fine for about, I'd say, sort of another 6-7 months. Started again second half of last year. And then it started getting better just when I was about to have the injections again. Started getting better in November, December time, so I left it. And then about 3 weeks ago, I was fine one day, and the next day, went to work, sat down, couldn't sit down for more than a couple of minutes. Tried to work. I work in finance, in private credit. It's quite difficult to work at your computer standing up, so I went home, tried to work for the rest of the day kneeling at my desk. And then by the next morning, I couldn't stand or sit, and just had to lie flat out on the floor. And the pain was in my butt, same place, in my butt, the outside of my lower leg and in my ankle. I had some injections again. A couple of days later, it didn't actually do anything. A couple of days later, so Easter Saturday, I ended up in A&E just because the pain was so bad, and then saw Mr. Malik the following week.
Thank you. And when Farid came to me in clinic, would you mind if I tell? Yeah. I went to collect him from outside. I see a person is lying on the floor in a prone position, legs both up. I was really surprised. So I said, I brought him in. And when he came in, he was unable to sit on the chair. He said he will lie on the floor and will give me his history. And that's what he did. Yeah. And he was weak in the foot as well and numb. So he was having a partial foot weakness. So obviously he has tried everything possible, and he was in a very bad shape. So I suggested him wait another couple of days because you have recently injection, see how the response is. But when I called him at home, he was again lying in the same position. We had a video call, and exactly the legs up, and he said he can't cope with that pain. So that is Farid's MRI scan. So if we see here, I just put the side of that MRI scan. It's not exactly the center of the MRI scan. The reason behind it is because I want to show you not the spinal canal, but want to show you the foramen through which the nerve comes out. So if we see here, this is the foramina, which is a wide open, and there's a disc below that. Here, foramen disc. This is foramen disc above. So these are foramen are open. When we come to the last foramen, L5S1, we see that's a disc which is migrating into the foramen and pressing on his nerve. And if we do the axial cuts, that was more interesting to see that. So if you see, that is his back of the spine, that is front, that is right side, and that is the left side. Yeah? If we see here, skin, that spinous process, this is the spinal canal. And there's not much in the spinal canal. Just look at bit of diffuse disc bulge here. But if we see, the disc is all migrated from here, and this hole is a disc up till here. This hole is a disc. So it come out of the foramen and line some in the foramen and some outside the foramen. And because here lies our spinal ganglion. Ganglion is the brain or heart of the nerve. That's why if anything irritates the ganglion of the nerve, that's very, very painful. That's why he was lying in that position and tried to give the relief himself. So if we are doing a standard surgery, I know you guys won't do surgery, but there are surgeons sitting here. How we do that? There's no way we can approach here with a traditional approach. Because if I have to do this surgery here, the disc is here. If I enter into the canal, I can't do anything. I can't retrieve that disc. There's no way. The only way I can do that is I will go in and take the whole this facet complex out. And if I take the facet complex out, then the disc is underneath that, then I will manage to remove the disc. But if I remove the whole facet complex, this means I have destabilized the spine. So what I will offer the patient to? Our fusion surgery. From day one, from the very beginning. There's no other solution. You can't get the disc from any other route here at L5S1. And if I fuse him at that level, then after 4 or 5 years, he will end up with a problem on the adjacent level, and then the adjacent level. And Joel is here, he's done, how many surgeries you have? 7. So then it keep on increasing and creeping. So I think we are lucky that we got this technique now, which we call the endoscopic discectomy. Because with the endoscopic discectomy, you don't need to come through the traditional route from the back. You can come straight from the site, straight into the foramina, and remove the disc. Now I will describe this a little bit, how we do that and when it started. I think initially first surgery for the lumbar disc was done in 1934, where laminectomy was performed. Then with the microscope in 1968, we started a microdiscectomy. And then in 1993, we started the endoscopic discectomy. But in 1993, we are doing in-out techniques. So the people was getting into the disc space. And if you enter into the disc space, it increased the chance of recurrence. And that was not right technique, so it was stopped. So its technique is revived now, actually. And we talk about the muscle. So this is the multifidus muscle, which maintain the segmental stability. The way I'm standing now, and what is muscle, which active muscle is now at this particular moment, is the multifidus muscle. They are maintaining by every level segmental stability. That muscle become active when we stand. So if we do any surgery which involving cut in the middle, this means this muscle is attached to the spinous process and to the transfer process. So if we give any cut in the middle, this means we get rid of that muscle. That muscle will be damaged at a segmental level. And with the endoscope and with the minimal invasive technique, because we are sparing this muscle, we start coming from lateral, 8, 10 centimeters away from the midline, and we can save that muscle. And it's a short operation, small blood loss, quick recovery, patient can go home on the same day. And the most importantly, we are doing this under local anesthetic and sedation. I haven't done even a single discectomy under GA because it's a very small procedure. I want direct neuromonitoring because my instrument goes through the foramen through which the nerve is coming out. So I want a direct feedback from the patient. So if I need to change my instrument, I should do that. And advantage with that is if somebody is unfit, cannot have a surgery under general anesthesia, or if patient is morbidly obese, because even if the patient is very big or very small, the incision, because the scope is 7 millimeters, so the incision side will only remain 7 millimeters. So it's good for those patients. I think this is the studies where they compare a day before surgery, day after surgery, day 3 and 5, which Imran was mentioning. That was the initial comparison was between the tubes and what the traditional surgery, and it clearly shows that the CPK, the muscle damage, was much higher with the traditional discectomy than with tubes, and the p-value was significant. Similarly, visual analog score was much better in the people who have got the muscle sparing, which was tubes, than with the traditional surgery. And this is a direct comparison between the similar way, day before, day after, 3 and 5 day, between the endoscopic versus microdiscectomy, and it clearly shows that it has got a significantly advantage over the traditional surgery. And the outcome in terms of surgical outcome was the same. So how we do this surgery? Rather than coming, as I said, traditional approach from the back, we enter straight into the foramen on target. And we shave the disc off. I usually give an example. So if somebody has to come and move this computer from here, there's a two-way. One is to break the ceiling and come and remove it and then go back and repair the ceiling. Other is to walk through the door. So this one, which surgery we are coming from the back, we are breaking the ceiling because we come from the back, we remove the bones, we shave the muscle off that. Then we go and first thing we encounter is the nerves. So we have to retract the nerves and take everything from the side, and then we go and remove the disc. And then we have to stitch it back. While this is the tradition, this is the normal door. So if you enter through this door, you are not violating the spinal canal. You are straightway going, that's a disc, and you're just removing the disc. So this is just the anatomy of the nerve. This is called the Camden triangle. Camden was the one who first described that. So how we enter there? There is an exiting nerve root which is coming out the foramen. There's a traversing nerve root, and in between it forms a triangular space. That's what we normally use to do the endoscopic discectomy. Another picture of Camden triangle. And that's how we bring our instrument scope. We are aiming, upper half is the nerve and the lower half is free. So we enter into the lower half of the foramen. And that's how our needle placement is. If the lateral view, AP view is showing that we are coming in the lower half and we are just stopping at the medial pedicular line. And that's how it looked like when the disc come out. And that is Fried's case. So I pulled the whole disc out in one go. That is the disc fragment. So how are you feeling then, post-op? That's important. Share your experience.
I feel fantastic. I mean, it was 3 weeks, this most recent instance, it was 3 weeks of the most intense pain I've had. I could only lie on the floor. I couldn't leave the house, couldn't walk, sit down. Basically, I said it was like lockdown, but without any chairs. And I left the hospital. I had the operation on Saturday. I couldn't sit down, so I got the tube there. I lay on the platform. I lay on the carriage. I made it to the clinic, and then I walked to the tube afterwards and sat down on the tube. I walked home from the tube. I sat on the sofa in the evening, and I'm a normal, functioning human being again. This was last Saturday.
Thank you very much. And thanks for sharing your experience. I will not ask Fareed, but I will generally say, so this is the midline, and that is the scar. And this is another patient which I usually give an example. It was done by an orthopedic colleague 10 years back. This is the midline. He gave that C-shaped cut. And he did the surgery. Patient got the recurrence. This is my now cut. I did the divisional with this small cut. But thank you very much. I will finish here.